Start recording. I did start it a little bit early. I just like to give people time.
Well, I'm going to run to the bathroom real quick.
Sounds good. Hi, everybody. Thank you. We'll get started in just about a minute or so. I see somebody raise their hand. John, I'll have you look at that. I'm gonna, since it is 7 o'clock, Linda will be right back. Oh, she's back.
I'm here.
I was gonna say, I just have some housekeeping stuff to go over before we start anyway. So while people are still joining, on behalf of the Epilepsy Foundation of Wisconsin, we want to welcome you to this week's virtual meetup call. Thank you so much for being here. For those that don't know who I am, my name is Alicia Thompson. I'm the program manager here at the foundation. We also have John. I want to say hi, John.
Hi, I'm John. I've been working with Alicia for about 2 years and been with the foundation as a staff member since about 2013. I work with communications and social media client support.
Thanks, John. We also have Linda Allen with us, and you'll actually get to meet her in just a minute. Just want to do some housekeeping stuff before we get to that. So please know that we are recording this VMU. You can find it on our website and our YouTube channel by early next week. And our website, John can type it in the chat, but it is epilepsywisconsin.org. And also, attendees on this call tonight, just please know you are muted and your videos are off. But we do encourage you to ask questions. We'll have time at the end when Linda is done presenting for you to ask questions. And in order to do that, you can use the Q&A button at the bottom of your screen or wherever it is on your screen. John and I will monitor those and then we'll ask them and Linda will be able to answer them. If there is something you think of after the fact, or if you're just not comfortable asking right here tonight, you can use our connect@epilepsywisconsin.org email, which John will also type in the chat section for you.
It's in there.
Thank you, John. You can submit your questions. If something comes up after, we'll get them to Linda and then we'll get the answer back to you. And then just know for sake of time, some of the questions, not all of them may get answered this evening. I believe that's all the housekeeping stuff I wanted to go over. So Linda, I'm going to turn it over to you and I'll get your slides up right now.
Okay, well, thanks, Alicia, and welcome to those who have joined. I saw some people say hi to me, so hello, it's good to see everybody on here. And my name is Linda Allen. I'm the Epilepsy Program Coordinator at Froedtert Hospital and the Medical College of Wisconsin. So I'll just tell you a little bit about my background before I get into this. I found my niche in epilepsy almost 30 years ago. I've been at Froedtert doing the same job, which is pretty rare for an RN to have the same job for that long. So I started there in 1991, developed the program. And what I'd like to talk to you about tonight is exactly what I talk to patients about every single day. And that is our epilepsy surgical workup. How do we decide who's a good surgical candidate? And how do you decide if you want to pursue surgery of any sorts, which I'm going to talk about tonight, how you decide to move forward. Next slide, please. So the first thing that I talk about with patients is intractable or refractory seizures. Those are interchangeable words. Intractable or refractory means uncontrolled. And our goal with our patients is to have 0 seizures and 0 side effects. So if you don't have 0 seizures or 0 side effects, and you're seeing a primary care doctor or a neurologist, then it may be time for you to come to an academic center that has an epileptologist at the center. I work with 5 epileptologists at our facility, and then 1 epileptologist at another facility, which is part of our group. So we have 6 total epileptologists that only see people with seizure disorders. And if you're having uncontrolled seizures and you've tried more than 3 seizure medications in either monotherapy, meaning just taking 1 medication, or polytherapy, meaning taking more than 1 medication at a time, it may be time for you to think about coming to an academic center for an evaluation of your seizures. So how many seizure medications, anti-seizure medications is too many? Well, we have some patients on 3, 4, 5, even up to 6 seizure medications at a time. So I don't think there's any set number, but most people are on, when they're coming to us, are on at least 2, then still having breakthrough seizures. So the next thing that we would do then with you is we would say, I think it's time for you to come into our monitoring unit to figure out where your seizures are coming from and if they are seizures indeed. So we bring patients into our monitoring unit for 3 purposes. We bring them in for A, classification. Do you have epilepsy or not? B, medication adjustments. So we can bring you into our monitoring unit for a safe way to make you have change from 1 medication to another medication. And then the last one that we bring patients in for is our surgical evaluation to see if we can find what's called a seizure focus on where your seizures begin. So the monitoring can tell us where your seizures begin, be it frontal, temporal, parietal, or occipital, or sometimes it will just tell us right versus left. Sometimes it tells us in the monitoring unit if you have a focal onset or if you have seizures coming from all over your brain, which is a generalized onset. So what's next after we do the monitoring? Next slide. So what do you expect in the monitoring unit? When we decide that we're going to bring you in, we have pretty strict rules for our patients when they're coming into the monitoring unit, because we want to make sure that patients are safe. We are provoking a seizure and we need to make sure that we can maintain your safety. So everybody knows that you can have injuries from seizures. So we want to protect you because we're making you have them. So in our particular monitoring unit, where we have a 6-bed monitoring unit at Freighter, what we do is we bring you in, hook up the 28 electrodes on your head, we glue them to your head, and then we put you in a monitoring room where you have to remain in bed all the time except to go to the bathroom. When you do go to the bathroom, we also require that our patients wear a helmet when they go to the bathroom, a gait belt, which is just a belt around the waist for the attending to, for the person that's taking you to the bathroom to hold on to in case you have a seizure. And we also require that somebody be with you in the bathroom. A bathroom can be a very dangerous place to have a seizure and get injured, and we don't want that on our watch. So when you're coming into the monitoring unit, we have you watched 24/7 down the hallway in our epilepsy monitoring unit room, where you're on a closed circuit television. And we also have somebody, we have alarms that can go off when you're having a seizure, and then all the available staff come in to assess you during the seizure and make sure that you're safe, and then do our assessment in the things that we assess when we're in the monitoring unit are, we assess your consciousness during a seizure. So how do we do that? The first person that comes into the room when we're monitoring you for your seizures, it tells you to remember a color. Some people say a word. I even tell family members to do this at home, because this is very important for driving restrictions. Because if you say a color during a seizure and they can't remember it, That means you've altered your awareness during the seizure, and that's indicative then of an altered awareness. You cannot drive in the state of Wisconsin for 90 days. So that's very important for us to assess. We assess your language skills. We have you talk during the seizure, or after the seizure is complete. And then we have you do some commands to see if you're understanding us. So when we're monitoring you in the monitoring unit, if you're coming in for classification, seeing if you have epilepsy or not, we only need to really see one seizure. If you're coming in for a pre-surgical evaluation, we like to see 2, possibly 3, the more the better, 3 seizures to see if we can make sure that they're all coming from the same area. Now, I'm not going to get into it tonight, but one of the other things that when I was saying to make sure you have epilepsy, 20 to 30% of the people that come into our monitoring unit have what's called psychogenic non-epileptic events. And what those are psychological events rather than physiological. An epileptic seizure is physiological. There are electrical changes in your brain that make you have the seizure. Well, with a psychogenic event, there is some stressor from your past that every time your brain starts to think of this stressor, it mimics seizure-like behavior. And that can elicit this type of event that sometimes people are on seizure medications for this, and we can get you off of your seizure medications then and make sure that you get the proper treatment, which is psychotherapy. But I'm not going to get into that one tonight. So if we find out that you have seizures and they're coming from a part of your brain, and you want to then pursue looking into epilepsy surgery, how do we move forward with the evaluation? Next slide. Everybody that has seizures should have an MRI. It's a given. You want to make sure that your seizures aren't caused from a brain tumor or any other thing that we could possibly find for doing surgery for. So all of our pre-surgical evaluation patients at our facility have what's called a 3 Tesla MRI. There's different magnet strengths, and the 3T is the strongest FDA approved strength. There are facilities that are testing an 7 or 8T, I can't remember what it is, Tesla, but those are not FDA approved. So we do a 3T MRI, and we inject contrast into your IV to assess for any kind of abnormalities that could cause your seizure. About 1/3 of the people that have epilepsy have an abnormality that we can pinpoint. A lot of times though, 66% of the population that have epilepsy don't know why. That's called idiopathic. And it's unfortunate because everybody wants to know, why do I have seizures? And in 2/3 of the people that have it, they don't. But sometimes an MRI can find scar tissue deep in your temporal lobe called the hippocampus. It can find lesion abnormalities such as a brain tumor. It can find strokes. It can find blood vessel abnormalities such as an AVM, or sometimes people are born with an abnormality called a cortical dysplasia. And all these lesions, anything that's abnormal in your brain is called a lesion. All these lesions can cause seizures. Now, usually if you go to the emergency room especially following your first time seizure, you're going to get a CAT scan. But then we also recommend, if you're moving forward with any kind of pre-surgical evaluation, that you have an MRI. I'm going to talk about a functional MRI later in my talk. Next slide. The next step, after we find that you want to pursue the evaluation, and remember, this is elective. You make the choice. We don't make it for you. So if you do find that you have epilepsy and that we think that we can find an opportunity for some type of surgical evaluation, we move forward. Now, sometimes people want to just stop here. They know that they have epilepsy. They know they're uncontrolled. Starting a new medication, you have probably, after trying 3, every time your seizure freedom diminishes each time you start a new medication, unfortunately. And so this is the opportunity then to say, hey, what should I do next? And the next step that we would do then after you have the video EEG monitoring is what's called, it's a long word, it's called neuropsychological evaluation. Perhaps some of the listeners on here tonight have had it. What it tells us is each lobe of your brain has a job to do. And we want to figure out, is there any area of your brain that's not working at the same capacity as the rest of your brain? So this neuropsych test, it can localize where your seizures come from. Localize means it can pinpoint sometimes where the concern for seizures are. Other things that it tests are, I wish I had a nickel for every single person that said to me, I really have problems with my memory. Because if you have temporal lobe seizures, your memory is being affected. Every time you have a seizure, it can slowly take away that function of where the seizure occurs. So neuropsych testing tests your memory function. It can test your language function. It can test problem solving, your thinking of how to solve problems. It tests motor function. This test is ungodly long. It's about 4 to 6 hours. And it also includes a test called an MMPI. It's a multiphasic, Minnesota multiphasic personality inventory. Well, that's a long word. What does it test for? You know, a lot of times people that have any kind of chronic disease have problems with depression. It's not uncommon. And if we're looking into doing epilepsy surgery, we need to make sure before you have surgery that you don't have any kind of depression, because anytime you have any kind of surgery, a surgery can cause depression to worsen. Now, I didn't say brain surgery, I said any surgery. So we have to make sure that you're treated for that depression prior to getting any kind of epilepsy surgery. So that MMPI can detect depression. And when you do the neuropsych testing, it also gives you your IQ. Now, sometimes people don't want to know what their IQ is, but it does give you your IQ. The neuropsych testing can determine which is your dominant hemisphere sometimes, but then there's going to be other tests that I'm going to talk about later to determine what dominant hemisphere. And what that means is which side of the brain do you talk out of? Most right-handed people talk out of the left side of their brain. So we have to confirm that and know where your speech is if we're going to be doing any kind of surgery on your brain. Next slide. So the next one is called a MEG scan. It's magnetic encephalography. So when you're doing an EEG, remember when you had the video EEG, when you had all those wires on your head, that's measuring your brain waves electrically. And what a seizure is increased electricity. And the EEG can figure out where that increased electricity is. What a MEG scan does is it's a non-invasive tool, and this is a picture of it, that we have at Freighter, and we have one of the only ones in the Midwest. The MEG scan measures your brain waves magnetically, because seizures can give off your brain can give off a magnetic field that can determine abnormalities of where seizure onset starts. The MEG scan, you get all of the wires glued back on your head, because we're also running an EEG simultaneously with the magnetic scan to determine if there's any differences. And sometimes the magnetic scan picks up things that the EEG doesn't. So we do both at the same time. It's about a 4 to 5 hour test, and it can assist our epileptologists in deciding where the seizure focus might be in planning for what's the next step with surgery. It can also study your language, which side of the brain you talk out of, and your motor function at the same time. During the scan, we can do those two tests as well. Next, some people may get what's called a PET scan, or a positron emission tomography. And that's a long word. And what does it test? It tests where your blood sugar goes in your brain. So during this scan, they make sure that your blood sugar is normal, and they hook you up to EEG, and I'll tell you why in a second why you're hooked up to EEG. They inject a radioactive material, IV, and then you have to rest for a bit. And during that resting stage, that's when that radioactive material goes up to your brain. And then they do a scan. And the scan is measuring where that glucose went in your brain. Now, most people, the glucose should be exactly the same in the entire brain. But if you have a seizure focus, what it tells us is there's a decrease of glucose in that area, and that could be where the seizures are coming from. Now, the reason why we do this with EEG is because if you're having a seizure during the injection in that 1 hour period of it's going up to the brain, which can happen, then there's an increase of glucose in that area. So that's why we do it, to get a better result of the diagnostic test. So everybody the people that have lesions, though, we don't do PET scans on, because it's going to be abnormal in that lesion area where the uptake of glucose is. So, but a lot of people that have normal MRIs will get a PET scan. Okay, next slide. So the last test that we do on all of our patients is a functional MRI. Remember, I said we need to know what side of the brain you talk out of. So we can do in the MRI scanner, they have software that will light up the area with your language function. It can also light up the area with motor function as well. And this is non-invasive. Everything is done in the MRI scanner. What they do is they instruct you. It takes about an hour to do the instruction. And the instructions tell you what they're going to see in the scanner. So they have a little screen in front of your face. And in this screen, they're showing you animal pictures. And they're asking you if this animal is native to the United States or not. So, and they test you before to make sure you know how to do it. And then you have a little button inside, and you're looking at the screen, and you push a button if it's native to the US. And when the scan is done, because you're thinking, and that's a language process, it will light up that area. And it's, like I said, it's non-invasive, so there's no kind of risk in learning where your language is by doing the functional MRI. The functional MRI takes about 2.5 hours. All of these tests, except for the video EEG, are done as an outpatient. Now, there's another test that a lot of facilities utilize, and we rarely do it now because we have the expertise of the functional MRI, which, by the way, was implemented and started at the Medical College of Wisconsin by Dr. Jeff Binder. He's like the pioneer of the functional MRI. But if a person is not able, if their IQ is low, or we really want to confirm their memory testing, then we need to do what's called a WADA. And a WADA is the name of the procedure. WADA was Dr. June WADA who invented the procedure. And what it is it's done with an angiogram study. An angiogram study is they put a teeny little tube, it's called a catheter, into your artery in your groin called your femoral artery. They feed that up to your neck and it's done, everything's done inside. First they numb your groin to make sure that it doesn't have any pain. And then they feed this tube up to your neck, and they inject dye and take pictures of your blood flow in your brain. Once they know how your blood flows in your brain, then a team comes into the angio suite, including neuropsych, myself, and an epileptologist to test your EEG brainwaves. And they inject a medication called sodium amytal. Now, if any of you read mystery novels, sodium amytal is truth serum, and it's injected IV to make you tell the truth. But if you inject it directly into the brain, it puts that half of the brain to sleep for about 5 minutes, and it tests the language function on the side that's injected and the memory on the opposite side. There are risks to this procedure, including the possibility, very, very low possibility, but there is a potential for stroke. So that's why we really try not to do WADAs. We try to do functional MRIs. WADAs are also take about 6 hours, including the recovery time. And it's a very costly procedure compared to the functional MRI. Okay, next slide. So now we have all of these tests done. And every week, our team of physicians, nurses, social worker, neuropsychologists, neuroradiologists, neurosurgeons, we all meet, and now we're doing it through Zoom. We all meet and discuss all those tests that I just talked to you about. And then we decide what's the next step. So the next step, so now I'm going to get into the different types of surgeries that are possible for you to decide on. So the first and one of the most common surgeries to decide upon is, can we take out a part of your brain safely without causing any deficits? And sometimes the answer is yes. Sometimes we can do it right away because all of these, so what I tell people is that all of those tests are like a piece of the puzzle. We put all the pieces of the puzzle together, and if there's one single area that can safely come out, we can do what's called a resection. Now we can do what's called a single stage, which is you come into the hospital, we know exactly where we're going to take out, and it's in your non-dominant hemisphere, meaning not your talking side. And remember, in most people, that's their right side. And we can safely take out the right temporal lobe with you asleep. And that resection is called a single stage. Sometimes they also do right frontal if they avoid the motor area. But if it's in an area of function, then we may have to do something else. And so sometimes if it's in an area of function, we can do a single stage resection with you awake. I've been in a lot of awake surgeries doing mapping of language. And then once we know where the language is, then we can take out that area of the brain safely as well. So that's a resection. We take out a portion of your brain, either asleep or awake, and in a single stage. Laser ablation is one of the coolest things that I've been at Freighter now for 30 years, and we're doing what's called laser ablation in certain circumstances. You have to have a very small area that can come out safely, and it's done in an MRI scanner where your head is in a head frame, and there's optic fibers. That teeny little fiber goes into the area where they're going to burn. And laser ablation is literally heating up that area of the brain, and it totally ablates that area instantaneously. Now I say instantaneously. This procedure can take hours and hours to get it to the right location and when you're burning it that quickly, you want to be precise. But the laser ablation, there is no cutting of the scalp, no shaving of the hair. You go home, believe it or not, the next day. So you're in the hospital, go to get your laser ablation, recover overnight, go home the next day. And the results, if we hit the spot, are very, very good for getting rid of your seizures. So that's one of the coolest techniques I've seen invented since I've started. And I've seen technology change since I started in 1991 dramatically. Implanting electrodes. So sometimes we know either left or right, but we don't know exactly which lobe. Or sometimes we don't even know left or right, but we know you have seizures and we want to see if we can pinpoint it. So what I tell people is Stereotactic EEG are utilizing depth electrodes, DEPTH. Some people think I'm saying deaf electrodes, and I'm not. So depth electrodes, I use the analogy when I'm teaching a patient. This sounds really corny, but I use the analogy as your brain is like a pin cushion. And these depth electrodes are implanted as like a pin going right from the surface all the way through deep into the brain. At our facility, we implant these electrodes using a robot, and the robot provides our surgeon with the angle to put them in to avoid any kind of blood vessels. And then you come out of surgery, either with them only on one side or on both sides. And once again, you're in our video EEG monitoring unit and provoking seizures. Once we have the exact location, then we usually go to the resection, like I discussed earlier. Another way that we can do invasive monitoring is using grids and strips. We hardly ever do this way anymore. A grid is a 64 set of electrodes, 64, how can I explain it without showing you? It's 64 electrodes on a little piece of plastic that we take, you're put to sleep, you have a craniotomy, which means the piece of bone comes off, and we rest this piece of plastic on your, it's not plastic, it's like silicone, rest it on your brain with wires coming out. Then we close you up, and these strip electrodes are the same, except they can go underneath the craniotomy and fan out to different areas. And then you're closed up, and once again, you come out of surgery, have seizures, and then we can even do what's called mapping of function, be it motor or language, off of the grid. And then you go back to surgery to have the resection and the grid removed. So those are the types of surgeries that we do for resection. Now, there's also devices that we can utilize for epilepsy as well. Devices are used for patients that aren't surgical candidates, they're not good surgical candidates, or they absolutely don't want to have brain surgery, or their seizures are coming from an area of eloquent tissue, meaning tissue that you can't lose. So that's speech or motor. And so we have different device options, okay? The vagal nerve stimulator, it was FDA approved in 1997, and it's implanted in the chest with a wire that's tunneled underneath the chest up to the neck, and it stimulates the vagus nerve. Now, when I was talking earlier about the video EEG monitoring, if you aren't a good surgical candidate, that we don't want to do all the rest of the tests, or you absolutely don't want to have brain surgery, you don't have to have all those tests. You can go right into the implantation of the VNS as long as you have uncontrolled seizures, okay? The DBS, which is pretty recent for epilepsy, just a couple years now. The DBS is the deep brain stimulator. And the deep brain, and I'm not getting into the VNS because that's going to be next week's talk, I believe. The DBS is implanted, it's two wires that are implanted in the thalamus and then coiled to a generator in your chest, and it stimulates the thalamus to decrease seizure activity. So the VNS stimulates the vagus nerve, the DBS stimulates the thalamus in your brain. Now, the last device is the RNS, responsive neurostimulator. The responsive neurostimulator is used for patients who have seizures either coming from both sides, and that's usually in the deep structure of your temporal lobe called the hippocampus, or your seizures are coming from an area of tissue that you can't afford to lose, like motor or language, or you've had surgery already and the surgery you did not attain seizure freedom, and we're going to put some electrodes around the area that we couldn't get out. So you get the implantation. So the RNS implantation is 2 electrodes implanted in the brain. They're depth electrodes or strip electrodes implanted in the area of your seizure focus with wires that come in. They get put into a little device that's implanted in your skull. And this device is a 24/7 EEG. And when it's set at certain settings, and when it senses a seizure, it sends automatically current to those electrodes to terminate the seizure in its path. And it works. Now, none of these devices we ever profess 100% seizure freedom. We never profess 100% seizure freedom with resections or laser ablations either. But statistics show that resections are about anywhere from 50 to 70% are seizure free. Laser ablations is about the same. VNS is approximately 50% of the patients get rid of 50% of their seizures, and the same with the DBS and RNS. The rates are about a 50% reduction in seizures. And with time, with all of these devices, your seizure freedom gets improved with time. So the longer you have the devices, the better your seizure rates drop, your seizures drop with time. So that's a lot of stuff that I've just told you about. I'll open it up now to questions.
Thank you, Linda. That was terrific.
I hope you learned
A lot
something.
of information. Yes, lots of information in there. Okay, there are several questions actually. No particular order, but from one listener, if you have 2 brain implants already, would it help to take any of these tests later?
Yes. So having the brain implants does not stop you from having the evaluation in the future. And just like if you have a VNS, you can also get, we just did this. We've implanted, our last 2 patients had VNS and we implanted DBS. So having one device or 2 does not preclude you from not moving forward in the future. We see a lot of patients also coming from other centers that have been implanted with devices, and then we say, okay, we can offer you another option. We see that all the time. So that's a really good question.
Okay. Could you elaborate on what an epilepsy event is? Is it the same thing as having a seizure?
I'm assuming that means a non-epileptic event.
Okay, I'm just reading it as it was typed in there. I'm assuming it's non-seizure as well, not an episode.
Right. Okay. So that would be a whole nother lecture. And your brain is really powerful and can make you do things, believe it or not, that you have no control over. Especially and a non-epileptic event. And so back when I started, back in the 90s and into the early 2000s, the old terminology was pseudo seizures. We don't call them pseudo seizures anymore because pseudo means fake. And fake, they're not fake, they're very real. They're very real to the person. But there's no brainwave changes when we are monitoring you on EEG. And it's a form of PTSD. And a lot of times I've seen patients that have had sometimes psychogenic events 20 years. And until they got monitored and figured out that these really aren't epileptic seizures, they've been put on one medication after another and adding more and more meds. And they didn't need them because they weren't electrical seizures. They were non-epileptic. So they were psychological events caused from some stressor from your past, that every time your brain subconsciously starts to think of this stressor, your brain takes over your body and mimics seizure-like behavior. And like I said, 20 to 30% of our patients that come in have that diagnosis. And some of our patients also have that diagnosis along with epilepsy. So that makes it even more complicated.
Okay. Mhm.
Thank you, Linda. Let me just look really quick what we have. Do you still do the fMRI for people that are non-verbal?
Oh, I've never had a patient, I think, that's nonverbal, but it's possible. Yes, you have to figure out where their language is if we're going to do surgery. And if they can understand the task, you don't have to, you're not talking in the MRI machine, you're pushing a button with your finger. So yes, it is possible.
Okay, very interesting.
Mhm.
Another question here, when you have surgery on your skull, that's a craniotomy, I'm gonna butcher it.
Craniotomy.
Yep, thank you. Right, and then does bone mend like skin or muscle?
Good question. Okay. So this is kind of corny what I tell patients, but when you're taking the piece of bone off, they take it off with a special instrument, a saw, okay, in the operating room. First, they take a drill bit, really teeny drill bit. They make 4 little holes, like kind of a square.
Mhm.
And then they take the saw and they connect the 4 holes and it pops right off and it's cut on an angle. So what I tell people, and people understand this,
Mhm.
is when they put it back on, think about putting back on the top of a pumpkin.
Yeah.
When you put the top of the pumpkin back on, it fits in there directly flush. And then they take 2 little titanium like rivets and they anchor those 2 titanium rivets on each side. And just like you break an arm and you put your arm in a cast, bone heals. Okay, it grows back together. So the same thing with the skull is that bone holds it just from those two titanium rivets hold it in from moving around, but eventually the bone will heal on its own, just like a broken bone in a cast.
It's very interesting. Wow. John, I'm sorry, you're gonna have to help me with the questions because now I'm
Okay.
sure.
Next one here. Does surgery ever affect a person's psychology, anxiety, personality, etc.?
Oh, it can. So that's an excellent question. Now, remember how I was saying about prior to surgery, we make all of our patients do that personality test to make sure that they're not depressed,
Mhm.
okay? Because a surgery can make you depressed. What we see a lot, and now this is anecdotal, but what we see more of is we see more depression with our right temporal lobectomies compared to any of the other lobes. So that's the major personality change, but it's not chronic, it's acute. So it's only for a brief time. Sometimes we have to add some medication to get somebody over the hump, but most of the time it's not a long-term side effect of the surgery. And that's the major one that we see is depression.
Okay.
Thank you.
If you get depression from your testing or surgeries, is it the same thing as clinical depression?
Yep, it is very much the same. Yep. And it's treated the same. But most of the time, people will it will just go away on its own and we don't need to give medication. But I always warn patients when I'm doing my teaching before surgery that it's not uncommon to feel sad. And, so we get rid of somebody's seizures and they should be really happy, right? Well, sometimes they're not. And it sometimes takes time.
Okay. Another question here. I have the deep brain stimulator. Sometimes the wires shift over the collarbone. Is that something to look into?
It's possible. Yeah. There's not a lot you can do about that though, because there's anchors that they anchor them in with, and the same thing with the VNS that they anchor them in with too. But you may want to talk with the surgeon to see if there's a problem. to check the impedance of your device to make sure that that movement or shift didn't do anything to increase the impedance, which is leaking out electricity.
Okay. Let's see here. Is the MEG scan in place of internal monitoring or an addition?
It's usually in addition. So in all the years that we've done this, it was only in place of in one patient. But it's very nice to help our doctors guide them because it shows exactly where the in between abnormalities are. Then that would be where they would put the depth electrodes then. So that's, your brain's huge and that's a lot of territory to cover. And these depth electrodes are so thin so that the MEG scan guides them where to put the electrodes.
Okay. Let's see here. If I already have metal inside my head, can I still get an MRI?
Most people think they have metal. Most people, things that are inside their head are titanium. And then you can have an MRI. All of the, screws and that doctors use in your spine and the screws in your skull, that's all titanium. The only times that I've seen patients that can't have an MRI is if they've had really long time ago surgery and they did use metal or bullet fragments.
Oh, okay.
Bullets, you see what you're learning tonight? People that have bullet fragments can't have inside their body, can't have an MRI. And pacemakers, you can't have an MRI.
Okay. Let's see here. What is the infection rate for these surgeries?
It's about 5%.
Okay.
For brain surgery. For the devices, it's even lower.
Oh, okay. Wow.
I would say 3% for the devices and 5% for the other for brain surgery.
Okay. All right.
There's always a risk of infection. I mean, you can have a tonsillectomy and have a risk of infection.
All right. Let's see. Can medication also have a negative effect on memory?
There are some medications that, especially like topiramate or Topamax, that can have the effect on your memory. But most of the time, that's the main one that has the cognitive concern is Topamax or topiramate. But most of the time, your memory issues are related to having temporal lobe epilepsy.
Okay. Another one here. Do MRIs of epileptic patients commonly show certain types of birth defects?
Yes. So like I said earlier, one of them is a cortical dysplasia. So it's the brain that when the brain is developing, it can develop and it can not develop properly, and it starts on the surface and go deep in. So you have like this unusual pattern of brain going from the surface to the deep side, and that can be from birth. Another thing, you can have an in utero stroke. So you can have a stroke when you're inside your mother, you can have the fetus can have a stroke and be born with a stroke, and so the MRI would show that too. And that would be from birth.
Okay. I am not seeing anything else at this point. Alicia, how about you?
I think you covered all of them, John. Looks good.
I would just encourage anybody now who does have questions to go ahead and submit them now. Let's see here.
Somebody said this was fantastic, Linda. Thank you.
Oh, good.
Yes, as you were doing your slides, I actually texted John and I said, this is incredible. There's just so much out there now that's available.
Oh, there's so, I've seen technology change so much since I started. When I started, we were still using paper EEGs where the techs had to literally fill the ink wells with the wires that were on the paper, and you would see the wires going really fast on the paper. And then we went to VCR tapes, and we would videotape with VCR tapes the patient's seizures. And now everything is digital and wireless. And I mean, it's just, the technology has just been such a huge, amazing change. And the RNS is like one of my most favorite inventions, having a 24/7 EEG in your head. I mean, who would have thought that 20 years ago?
That's crazy. Yeah.
Yeah.
We just have a couple comments. Thanks for taking me down memory lane. And also thank you, Linda. I learned so much.
Great.
Yeah.
I am also putting in, for those that joined late, our general email. If you think of questions after we're done, please go ahead and submit it to the email I just put in to our chat box, not the Q&A. And I'm also putting in our general phone number as well.
And you guys are welcome. I can give you my work number. I mean, this is my life. My job is to educate. I have a passion for educating people on seizures, because there's so many people that just don't know. When they come to our center and they say, boy, I didn't even know any of this until I came to the center. So do you mind if I give out my phone number right now?
That's up to you.
Yeah,
okay. So get your pens ready, everybody. And
I'll put it in the chat box too. So
okay, my work phone number. I'm not giving you my personal number. my work phone number is 414-805-3641.
okay.
Got that, John?
And it's in the chat box there now for those of you that weren't able to write it down. So.
Great. Well, we will give people time to write that down if they want. But Linda, thank you so much. Like, I think you've heard, everybody learned so much. We appreciate your time. And if any other questions come up, we'll be sure to get them to you, or people can just give you a call too. But yeah, thank you very much. We had fun.
All right. Thanks, everybody. Bye-bye.
Thanks.
Bye-bye.
Bye-bye.